Before we start, thanks everyone for joining us this morning. As you know, we do record these webinars and they'll be put onto our NCAS website. Before we start, as we gather for this meeting, physically dispersed and virtually constructed, let's take a moment to reflect the meaning of place, and doing so recognise the various traditional lands on which we do our business today. We acknowledge the elders past, present and emerging of all the land we work and live on, and their ancestral spirits with gratitude and respect. So I'm really thrilled to have Richard speak with us today. I did see him present around health literacy at Peter Mac a few weeks ago, and it struck me that it was an area of huge importance to antimicrobial stewards across the world, as will come through his presentation today. So Richard is the Director of the Centre for Global Health and Equity at Swinburne University, and also holds honorary positions at the University of Copenhagen in Denmark and University in Thailand. He's an epidemiologist and health services researcher, and for most of his career, he's held prestigious research and HMRC fellowships and is currently a principal research fellow. He's globally known for his practical research and tools in the areas of health literacy, health equity. Although he primarily works in non-communicable diseases, he's also worked in communicable diseases and has actually developed the main patient-reported outcome measure used by pharma to evaluate influenza and RSV and other vaccines. And much of his work has been translated into 60 plus languages. He's developed a wide range of tools for evaluation, some of which I'm sure maybe you'll be interested in looking at. And he's also an advisor to the WHO, hugely cited, and I'm very thrilled to have you speak with us today. So without further ado, Richard, I'll let you go.
Thanks very much, Kaz, and really I am a night owl, and with my work with Europe and Africa, it's mainly work late at night, so it's a rare thing to be actually intellectually active at this time of day. But as I go through, don't hesitate to interrupt me, ask questions. Very happy for that sort of work. We can make this interactive. Okay, so just some of my practical experiences, as mentioned. I have developed patient-reported outcomes or questionnaires for influenza and RSV. I've been involved with most of the biggest pharmaceutical companies in trials and advising on those particular areas. And I actually started at the Royal Melbourne Hospital, my main academic career in Melbourne Uni, with John Hopper in epidemiology. But at the Royal Melbourne, I got frustrated with patient education programs and developed a new tool to evaluate those. And then towards the end of my time there, I began developing the field of health literacy, because I noticed when people coming into the ED, they would often not know why they were there, or what this stuff that people had suddenly told them was about, or what this bag of pills was for, or who just said what. They didn't know very much at all, nor should they. Suddenly they're in the hospital and they've been trying to get by in life, and suddenly they're in this really complex foreign environment. And we expect so much of them to be able to manage their treatments, manage their care. So I really moved away from patient education, because I saw a lot of those sort of programs were increasing social inequalities in health, because the well-empowered, educated people perhaps taking part in programs. And so I uncovered this field of health literacy, which I'll go through a fair bit today. And the questionnaire I started developing at the Royal Melbourne has now become probably the most popular tool, or useful tool, I would hope, in many settings. This diagram here shows you where licenses have been issued in the last 4 or 5 years. And in the area of service design, and again at the Royal Melbourne, I could see tremendous inequality and perhaps chaos with the waiting list for hip and knee replacement. And with the then Director of Joint Replacement Stephen Graves, and a great partnership with the state government, we co-designed actually a system where every hospital had a way of formally identifying who really had the need for knee replacement. And through various processes and co-design initiatives and local ownership, this became implemented in all public hospitals across Victoria. And it's been in place for over 10 years. And it's really increased equity and maximised conservative treatment and made treatment much more consistent across that whole sector. And it's still in place today. And I understand that community practice is still in place with the different model of the practitioners in the front line, primarily physiotherapists and other allied health professionals and nursing who actually put things in place and make that run. So I will draw on that experience a bit because that was a remarkable intervention which has stayed there. So that sort of work also led me towards really trying to understand this business of intervention development and implementation science, and develop something called Ophelia, Optimising Health Reach and Access, which I'll take you through shortly. So how do you develop interventions that are useful and get implemented and stay there? That's what we become really interested in. And I've done a range of initiatives in different parts of Australia and different countries, and I'm currently leading a very complex consortium with University of New South Wales and Newcastle University to develop the New South Wales Mental Health Commission Health Literacy Responsiveness Initiative. Health Literacy Responsiveness has quite a bit in parallels with stewardship, I would think. How do you make this system more responsive to the needs of people in the community? And indeed, I've been engaged with WHO in quite a few settings. So I had the privilege of seeing very different healthcare systems and processes in place, and developed a way in which communities can co-design and implement. So here is the biggest kind of quandary or question I want to go through today is how can we ensure the interventions and services redesigns that we do or we select are not weak, only suitable for the average, easy to find patients, only useful for highly empowered people, only useful for deeply committed clinical departments who have great resources, and that they're actually hard to implement in the real world, and that actually they just disappear when the project funding stops and the particular people aren't pushing it anymore. Of course, a lot of projects can look good, have fashionable theory, be pushed by a powerful person, or have an impressive story and lots of funding, but they're not actually wanted, they're not scalable, they're not really sustainable. So the big question I've been working on is how can we stop wasting the billions of dollars around the world due to poorly designed and implemented research? Can we introduce more system into this? So with Kaz and Arjun, initially I said, oh, well, I don't really work a lot in AMS, but I'm very interested in it because it's a huge area of concern around the world. I get quite a bit of exposure to this with the WHO and just because I'm interested in health promotion and public health. So here's a list of some of the things which was identified by Kaz and team as some of the urgencies in your area. It's the misunderstandings that people may have about antimicrobials. There's things that clinicians struggle with when trying to communicate with patients about allergies. Strong antibiotics do not mean they're better. Some infections cannot be treated with antimicrobials. The need for follow-up and valuing clinicians' judgment and expertise when the patient feels better. The difference between inflammation and infection. Why antibiotics should not be just used just in case. A range of issues in veterinary care, but this goes across all sectors. That the body is what becomes resistant to antimicrobials rather than bacteria. All these will be very familiar to you, I hope. And that was not all the list. There's even more urgencies in your area. Outside metropolitan hospitals, there's issues around workforce, and you need to engage schools, and then particular issues in aged care as well. So we'll come back to these and have a discussion later, I hope. And going through your wonderful website and looking at the core elements of microbial leadership, all these will be familiar. But we might return to these, see if there's any insights from these other fields that we can perhaps strengthen some of your processes. So thinking through why many of our interventions are not reaching or effective with everyone, in developing this model for some years and presenting a variety of settings. So this line here is the theoretical maxim that your intervention, your health service research program has maximum impact. It has 100% impact. No more improvement possible. Every practitioner is fully up to date. Every patient gets the perfect education, and they have perfect improved compliance or behaviour or insight. But when we implement things, we tend to get early and quick wins and sudden improvements. We invest more time and we get diminishing returns from the continuous work, and your program matures. And then there's a plateauing. It seems to be no matter how much more resources, money, time put into it, they don't seem to reach any more people, and it's not more effective. We think we can use health literacy concepts to optimize programs that are perhaps designed for the one size fits all, Mr. and Mrs. Average. But how do we reach the people we're not currently reaching or failing to be really effective with? And we think there's going to be a whole bunch of health literacy mechanisms that we can talk about that can help here. So this is where the big gaps are. This is where the big unknowns are. This is where we've got to do a lot more work for the people we're not easily reaching because of our one-size-fits-all programs. Having the opportunity to think about this and develop or think up, develop, implement a range of program settings. We're trying to study why some of our programs have been really effective and implemented and reached many, many countries. So we'll go through this again at the end, I hope. There seems to be 8 things consistently over the last 10 or 15 years who have been seem to be most important. So meaningful engagement of stakeholders explicitly in a discovery. Sorry, I need to have a drink. So meaningful engagement of stakeholders explicitly in a discovery, change or utilization focused intervention at every stage of the process. Every stage and ongoing. Number 2, establishing principles for development and implementation process and criteria for judging the value of the intervention. So stakeholders need to understand the value of the intervention and principles for developing and implementing it. Deconstructing and understanding the problem through problem analysis. Number 4, exploring analysis and understanding of context through situation analysis and readiness viewed as a unique element in each part of an organisation. An explicit process to decide to proceed or not. And then developing the innovation or the intervention as an explicit process with method. Using program logic models to define the program and with implementation work and evaluation work to run concurrently. And ongoing evaluation findings inform continuous improvement and implementation. Excuse me. So this has mainly been based on grounded work. By grounded, I mean that we're not using a priori theory or not one particular theory. We're carefully evaluating the entire system and thinking through, well, why has that worked? What's going on there? I come from perhaps a laboratory science background and found early on theory rather intimidating, and I couldn't understand a lot of the fancy words and concepts from these other fields. And really, most of my work has been a grounded approach, which is really stopping to listen to ordinary people in the community, ordinary and special people, ordinary and special practitioners and policymakers and managers, trying to what's really going on for them on a daily basis, and developing programs based on that grounded information. And I guess after that, perhaps developing new theory, but mainly trying to developing ways of really having impact. So we'll come back to this too. Interesting, last February, because of my work in different areas, we developed a four-pronged approach to COVID from our particular response. We had a big website, apps working with IT companies and all kinds of folks to work on early detection of COVID and then response management. A lot of this was about really trying to understand in a very quick way, mapping with geographers and many other areas. And then community impact and recovery areas, guidance support for individual and community responses to optimize experience and recovery. And I'll go through next some of that work. We're doing this, it's taken a year, paper in the Lancet, really trying to encourage governments around the world to focus on what are the local knowledge environments of people. What do people actually know about keeping safe? What are their motivations? What's stopping them? Where do they actually get the information from? How do they decide things? So this is really the heart of health literacy. How people come to know what they know and why they do what they do. But at the same time, we've been developing work in prevention and preparedness for pandemics and related prior to February 2020. And I'll take you through some of our work shortly around that we've been doing in the Mekong. But I haven't really defined health literacy specifically yet, so let me do that. Just three areas: community health literacy responsiveness, and health literacy of an individual. Most of the work to date has been focusing on the individuals, the problem, but perhaps we need to make our service and systems much more responsive to whatever health literacy people have. And perhaps the community health literacy, the assets and the kinds of, I guess, knowledge infrastructure that's within and around a community have a big influence. So starting with community health literacy first, we define this as what refers to health literacy related assets, that's the knowledge, resources and abilities, including of a community, including the knowledge that is held by people, the extent to which knowledge is trusted, circulated and adapted freely in a community, the health promoting customs embedded in cultural beliefs and norms, as well as traditional or emerging practices of daily life, and the relationships that people, the community has with the outside sources of information, and linked to family, peer and community conversations and interactions. And these are essential to determining community health literacy behaviours and outcomes. So the conversations and interactions that people have on a daily basis are critical within a community. So having a handle on community health literacy will give us insights on how to improve whatever health program that we're trying to implement. Very much linked to this is health literacy responsiveness, and we define this, or this refers to the extent to which health workers, services, systems, organisations and policymakers across government sectors and through cross-sectoral public policies recognise and accommodate the diverse traditions and health literacy strengths, needs and preferences to enable environments that optimise equitable access to and engagement with health information and services and support for the health and wellbeing of individuals, families, groups, and communities. So that's how we as healthcare providers and services and systems respond to whatever health literacy capabilities individuals or the community has. A more direct way to look at this within the healthcare system is that you might think that they've got people in a community. This is the great majority. This is 90, 95, 98% of people just going about their daily lives. Some will approach the healthcare service, but they may not get very far because of their language or who they happen to meet, or that they find that they went to the wrong door in a health service with a no wrong door, without a no wrong door policy. They begin receiving services to degree to which they can actually use it, and whether the service is responsive to their particular needs. And very few people end up being fully engaged and they fully understand their own health. So fewer people reach this end area here. And it's likely people already with higher health literacy and higher education and higher resources. And so this creates inequity. So it's the more resourced and educated people who can get all their health needs met. So really dealing as health literacy is a health equity issue. So now coming back to, I guess, the most popular issue as being individual health literacy. And we define this as people's knowledge, confidence, and comfort, which accumulate through daily activities, social norms, and across generations, to access, understand, appraise, remember, and use information about health and healthcare. That's accessing, understanding, appraising, remembering, and using information about health and healthcare. And it's for the well-being of themselves and those around them. So this is about health literacy individuals. So this is the main way in which it's been conceptualized in those settings to date. But as you can see, health literacy responsiveness is absolutely critical. And then the community health level health literacy is also critical. But most literature has been looking at individual health literacy as a test of a person's reading and health-related reading and writing ability. And so a lot of the literature has been using tools such as the Realm TOEFL or the NVS in your sign, or an audit of the written materials, and just providing more and more written materials. We did a whole lot of work at Barwon Health and a large regional health service in Victoria, and I think it was well above 95% of people said they didn't want more written material. They wanted written material in collaboration, in discussions with healthcare professionals, or they want visual material, or they wanted other kinds of stuff that they could read and engage with. But more written material isn't what they wanted, even though it's beautifully written material. And as mentioned earlier, we developed the health literacy questionnaire, which is really changing how health literacy is done and thought about in many, many settings. In developing this, we did this work at the Royal Melbourne, this early work, and rather than asking a person, what do you think health literacy is, or just making it up from previous questionnaires or previous theory, which tends to reproduce errors of the past, I guess, we went to the hearts and minds of ordinary people, and we asked them this broad question, thinking about your experiences and trying to look after your health or better your family. What does a person need to be able to get and use all the information they need? And we use a very egalitarian, a very safe process. It's called concept mapping. It's got brainstorming. The community themselves, the patients and practitioners, sort and organize the data. We do live multivariate analysis, and we do map interpretation. So it's a process really to work with the hearts and minds of people in the thick of things, then and there, to develop the concepts that we want to work on. And this is what the community came up with, 9 separate dimensions. There was another dimension also about local culture and customs, but that can't be put into a psychometric questionnaire because it's so dependent on the particular community you're working in. So these 9 dimensions, I'll just go through them very quickly so you get a sense of individual health literacy, at least how it's been expressed in Australia and then being reproduced in many other countries. The first dimension being feeling understood and supported by healthcare providers. Number two, having sufficient information to manage my health, actively managing my health, social support for health, appraisal of health information, ability to actively engage with healthcare providers, navigating the healthcare system, ability to find good health information, and understand health information well enough to know what to do, which is the one dimension which is most related to health-related reading and writing, which is how health literacy was commonly thought of previously. But you can see in here there's community health literacy elements, such as support for health. There's health literacy responsive elements, feeling understood and supported by healthcare providers, person's ability to engage with healthcare providers. If they're a tremendous practitioner, can really compensate for a person's ability. As mentioned earlier, this questionnaire we're getting a lot of experience in many, many countries now, many partners and many groups, all kinds of institutions implementing this tool to get new insights into health literacy. I don't really want to take you through the questionnaires used to measure health literacy in the past. This is just a medication label of the TOFLA. You get a point towards each question you get right, and a label for ice cream to test people's health literacy. But the questionnaire has even been used in the Australian National Health Survey and health surveys in other countries. 6,000 people is implemented by the ABS within the Australian government. So we've got good insight across Australia now of health literacy. Nearly 6,000 people complete the survey within the Australian Health Survey. It's linked to the health literacy survey, the questionnaire that I developed is linked to the many other elements, potentially including relevant elements to infectious diseases. I haven't looked at that part yet. But just very quickly, when people assess their own health status, with a particular dimension, ability to actively engage, actively manage my health, we see a larger proportion of people with pair of 4 health saying they have difficulties with their ability to manage their health. So this 10 to 15% of the population is where we're having the most challenges with, and perhaps where we need to concentrate our efforts in supporting the community to have a better chance of knowing what best to do with the antimicrobials. And the same also in the area of ability to actively engage with healthcare providers, when compared with having no chronic conditions, when people have got a lot of chronic conditions, 10 to 20% of people are having a lot more difficulty engaging with healthcare providers if they've got more and more complex conditions, or perhaps their socioeconomic status, or other reasons related to sociodemographics and bad luck in health. They end up having more difficulties. So it's this part of the population which is our biggest challenge. Okay, so we'll talk about individual health literacy. When people are engaging within a health literacy responsive environment, they can get their needs met well, and they're living in a very supportive community, things can go well. But people may have poor health literacy or have some particular health literacy challenges across those 9 or other dimensions, then it becomes more difficult for them. But if they're working in an unfriendly or complex or hard to navigate health service, or the conditions particularly complex, even for the clinicians, it gets more difficult to get needs met. And then if they're living in individualistic society, they're feeling stigmatized, they're isolated, and it's a hard environment for them, it's even more tricky for people. Can people be ready for this transition? Can we support individuals and community to be ready to understand antimicrobials should they get an infection? Can we generate what we call connected and live knowledge that's going to be useful in the future? This is a real challenge. How can we possibly do that? Because we need people to have the best chance of knowing what to do as quick as they can, because when there's a health crisis, it's much harder to think about things. and our clinical teams don't perhaps have the time to really explain it to people, what's really going on. So this makes it a real challenge. So can we strengthen community health literacy overall? Can we work on demand side strategies? We can talk about this a bit later. Can we have the community demand not to have antibiotics unless they're really indicated? And can they have the full knowledge of when and why to use them? Really interesting question. I just want to skip through this one. So just to work on so we have approached this in the Mekong in Laos and Cambodia in a grant funded by the Australian Centre for International Agricultural Research, because we really want to work out in language minority villages, how can we support people to be able to work in a very healthy way with their animals and their own health, and know what to do should a problem occur with their animal's health and their own health. We had started this before COVID, and hopefully it'll be taken up more widely. But basically at the village level, we do engagement with the village leaders. So we did in Cambodia and Laos, villages which were the majority languages, but also villages that were the minority languages. We need to test it in settings where the villages were really isolated. So the process is to engage the village leaders and get local ownership and recruiting of a village team. We did the village mapping, who lives where and who you listen to, or who's got the knowledge. And we trained the team to be able to understand and gather, map the village. We did interviews and data gathering using a standardized process, rapid analysis in partnership with the community members, and then feedback and planning. And so the village folks would actually draw a map of their village, and they'll develop particular plans. They'll identify who has the knowledge, what's been their history, why do they trust, who do they trust, why do they trust them. And so just this whole process of engaging the community in their own issues about their animals' health and seeing the patterns. And so many villages could then see what others do, compare what they do, and develop through the very local leadership processes. Even kids got involved. It wasn't just the village head, and we had the regional health authorities also involved in this as well. Now, I won't go through this in detail, but what we have with regard to access, understand, appraise, and retrieve and use health information, there's quite a lot of detail here that helps us understand what's going on for people. But in red is what's particularly important for live knowledge, because we want to support community members to have the knowledge at the right time, to be able to draw on it or find it really quickly so they can take appropriate actions. So this link's not just to the Mekong, but our daily practice in Australia, in anywhere really. What tend to be really missing and really useful is how to do information in the area of accessing. They need easy access to how to do information, as well as why to do and what to do. In the area of understanding, we need people to able to state how information is relevant to them, able to state how the information can be put into actions, able to explain to others, understand the principles sufficiently to undertake problem solving. This is what we really need to be if there's a new health crisis or a new infection. When we were there, swine fever really was taking over. One of our villages, in the morning there were animals, pigs, but in the afternoon they were all gone. They were all destroyed or carved up and sold, taken to other villages. It was really extraordinarily efficient and also not necessarily healthy, because sick animals were being distributed for eating. Appraise, decide if it's relevant for oneself, and decide if it's possible for you. And then to retrieve, remembering with the aid of notes or environmental prompts, the maps laid up on the village walls that I showed you before as who knows who and what information can be used. We need better information that's quickly accessible to support decision making. We need practical knowledge and problem solving. That's really important. And there's so much trial and error in decision making is used. So people try something, then try again, then try something different, and try something different. And that's just the normal process for so many people. So I hope you can see that we're trying to get really inside the hearts and minds and daily practice of people to build better processes, better tools, better interventions that are more likely to be effective. So we are doing this in Melbourne now, finally, after months and months and months of lobbying. Excuse me. So working with community health services across Victoria, working with people in the high-rise housing, caravan parks, shopping centres, to really understand their knowledge environment, I'm calling it, about COVID, being COVID safe, about using vaccines or not, and what has been shifting for ordinary people in the community. Well, actually, like these special people in these public housing, but also drawing very deeply on our frontline practitioners who have tremendous knowledge of their community, using them to, working with them to really uncover their practice. Which you could just talk amongst yourself a little bit. I might have a bit of a cough. We nearly got this going in PNG, but the INGOs, the NGOs we're working with, too many of their staff got COVID. And we could talk about whether this is useful in AMS thinking going forward. So what's different with our work? It's user-centered, not researcher-centered. It's bottom-up plus top-down. Deep understanding of causal mechanisms through local engagement and revealing local wisdom. And realist evaluation thinking. So realist is a way of thinking from the UK. It's really understanding in different contexts, there's different mechanisms that are more effective or less effective under different circumstances, and understanding why that happens. And working with co-design, it's not just on setting agendas, but it's all the way through to developing connected sets of interventions, implementation, scaling, and routinization. So co-design is all the way through, really generating tremendous local ownership. And we developed a systematic process to put this in place, which we call Ophelia, Optimizing Health Literacy and Access. We have explained all the theoretical basis in a paper here. This is mainly developed in the context of NCDs, non-communicable diseases, but different groups are using it in different settings. So in summary, we work with local stakeholders. We use questionnaires like the HLQ, the Health Literacy Questionnaire. We document local needs, strengths, and preferences. We do tremendous workshops to uncover local wisdom, not just of individuals in the community, but our best frontline practitioners and our managers. And then we use a very deliberate process for designing the implementation of the intervention. And then we do use quality improvement processes, plan, study, act, do to implement it. And really, we find it's very much linked to, in the health services setting, to participatory service development and quality improvement. Lean manufacturing, that's that person putting that screw in that car door who's got more of an idea how to do that than a manager. So it's that person who has experienced the health event or is experiencing it. What's going on for them? And having that as part of the key information developing interventions. In a community setting, it's also similar to participatory community development, such as assets-based community development. Other elements related to it is communities of practice and quality improvement collaboratives, very much quality improvement collaboratives, very much about the AMS system, realist program evaluation, design evaluation, that realist understanding context, mechanisms and outcomes. Intervention mapping, it's a whole process, a bit hard to understand from the Dutch group of how to develop interventions. Then we take a whole of community perspective, focusing on who is left behind, who's missing out, why, making sure it works for everyone, and cycling between top-down, bottom-up processes. We've been able to put this into a manual. I won't go through this in detail, but with a step-based process, very easy to use. But just to quickly go through, we have different dimensions or key mechanisms that may be important for a person to be able to have access to understand engagement health services and develop a digital health literacy questionnaire as well. The key point here is that people have different levels of strengths and weaknesses, and we don't know which they are. Every patient that you see has their own characteristics, and you won't, if a person's got great access to things or a great understanding, you won't give them more intervention. You'll try to find, in particular people, what's holding them back. You work on that. So our intervention development needs to be mapping the sets of strengths and weaknesses that people have. So we administer our questionnaires, then we do cluster analysis, which groups all the people with like characteristics across these different causal mechanisms. So this, using cluster analysis, very boring old software, which finds two people exactly the same score across the 7 domains and puts them in a group, and it just works right through the data until the whole population is sorted into people with like conditions, and we get very different patterns of demographics. And from this, we can develop clinical vignettes, which are evidence-based, based on the population. And from this, we can ask people in the community and practitioners and managers. First of all, we ask, do you recognise this person? What strategies could you use to help this individual? There are lots of people like this in the community. How could overall we work with these people? And we actually get hundreds and hundreds of ideas from community professionals on how to solve particular sets of problems for people in the community. We'll do this right across a series of vignettes. And then we can organise it in various ways, including impact with individuals, or what we need to work with individuals, what staff need to do differently every day, what we do different with community engagement, and what organisations and policy needs to change. So that's our process, where we organise these data across these hundreds of ideas and have a complete coverage of the solutions of what needs to be done. And the community will prioritise what needs to be done in sets of solutions. And this has been implemented into now WHO demonstration projects using quite a few parts of the world, which is really very cool. So I think I want to stop right about here. So it's been implemented in many settings. We're seeing here with health literacy, there's misunderstandings we need to counter. There's particular misinformation or lack of understanding people have, which are causal in the AMS issues. And then there's particular kinds of things that clinicians need to do, or implementation that needs to be done. And then thinking about the core elements of antimicrobial stewardship. I think there's different process could be done in the leadership accountability set. What sets of interventions could be in place, the actions could be put in place, could be perhaps more developed based on the causal mechanisms within your setting, and perhaps different processes could be particularly in place about education. Tracking and reporting is just so important. So going back to the orthopaedic waiting list reform, when surgeons saw there was a whole bunch of people on their waiting list who didn't need surgery, or people have been waiting with tremendous need for surgery for a year or 2 years, they thought, oh, that's wrong, get you those files. I want to see if your new system and your new tracking system is relevant. So that we found the core problems in the system which begin to really supercharge the healthcare reform. So I will stop there and we can open up for discussion.
Thanks, thanks, Richard. Every time I hear you speak, I just feel like this is the missing link to what all of us need to be stepping into in a more systems approach way. We do, first of all, Leslie Halls, who's one of our PhDs who worked in the general practice space, has said, comment not a question, thank you. It was really interesting, relevant for AMS and broader implementation science. And I'll be sharing the link to this talk and rewatching. Rhys Scarborough is one of our veterinary PhD fellows. Really interested in your health literacy questionnaire. One of the questions is about feeling that you have all the information you need to manage your own health well. Is there a problem with this question caused by unknown unknowns, i.e. people unaware of the information they lack?
It is very much self-report. And actually, we compared Somali refugees with Indian migrants and Chinese migrants in Melbourne. And we certainly found that actually all the scales, the Somali rated themselves much higher. So it's really important to do this within community, within particular subgroups of the community. But when we've actually interviewed complex patients and clinicians have been their case managers for years or an extended period of time, and we look at the concordance between what a person's actually saying and what their clinician really knows about that person, and we interview them in their own setting, we find the concordance between these questions, what's really going on for people, actually extraordinarily consistent. There can be areas like with social support for health where I remember a particular case where a clinician rated, oh, this person's got terrible, just no social support for health. Whereas the particular respondent said, oh, no, I'm pretty good. Their sons and daughters would visit them and eat her out of health and home and abuse her. But she was so thankful that she got conversation, she got engagement, unlike perhaps some of her other people she knew. So perspectives of the clinician can be different to people in the community, but the differences, like you suggest, overall on average, we get really very clear information, but it's never designed for individual decision making. Mm. You always have to be there with your client, verifying that in a very direct way. So it's not designed for that. We have other tools for that.
Then, Glenn Browning is our animal stream lead. Is there a difference with people's health literacy about themselves and their health literacy about their pre-verbal children?
Actually, I'm going to get you to read that one again. That's help.
Glenn, do you want to open up?
Yeah, I'm happy to talk. So I guess I was wondering, and I'm thinking about this as much from a veterinary perspective as anything else, but is there a difference between how people perceive their own health and how they might perceive the health of children that they're responsible for who can't speak because they're too young?
Well, there's been a number of studies, actually a large number of studies that expect new mothers in that family situation. And there's a lot of differences, but there's profound influence on the child's health and well-being dependent on the parent's health literacy. In fact, there's been a huge amount of work done out of Norway on a parental version, like the parent version of health literacy questionnaire, which is referring to my child with the disease. And then we're getting all these requests now for the questionnaire to be adapted in other settings like that. But also just this week, we've got a request from a veterinary team wanting, can we adapt this questionnaire to be useful for the animals that I look after? Which is just this week, we've got this request. So what we're trying to understand is the mechanisms behind why people act in a certain way, and then linking that to in-depth, kind of like group cognitive interviews, or those the ideas generation workshops where groups of people can really share their deep knowledge from years and years of experience, and then build the intervention. So the seeding questions, or the early information from the questionnaire, isn't the be all and end all at all. I'm an epidemiologist, but I just load measuring for measuring's sake. We actually have to understand their mechanisms and get them right and build interventions around them. So if there's folks on here who want to work with us about a veterinary version of this, then I think we should have a separate meeting around it.
So my question, Richard, is how you get going. You know, literally how you get going, and how do you recruit participants into the questionnaire? Clearly, this is an area of great need, particularly as we struggle with stewardship especially in the community, in primary care, as aged care, and you know, how do you get going is a good question, I think, for a lot of the people online.
Good question. Administering the questionnaire is very easy. It's been done in 500 places around the world. So it doesn't need to be an epidemiological approach. It's not like trying to get prevalence. You really need to work with some face-to-face interviews. So in the high-risk housing setting in Melbourne, we're about to go to the field. It's a mix of door knocking, where people are being vaccinated, and online surveys. So the mix is fine. When people are turning up to particular appointments, you try and invite them then and there. One of our PhD students did this emailing and letters to people who have been into the emergency department. So the main thing is making sure you get breadth of people, and the cluster analysis then helps to understand the different subgroups of people out there. So it's extremely forgiving from your sampling, but you've got to make sure that you hold the hand and support people who are, I guess, having the most trouble in their own language, to actually get those data. And that data collection process, clinically, carefully over time, it's doable. With the New South Wales Mental Health Commission, we've worked with, I think, about 10 different community groups, right across all kinds of people, from elderly, young people, and many other traditionally marginalised groups as well, to have some input from them. And so we're getting the full picture. We have the full picture there, and come up with 11 action areas that need to be acted on right across the sector to improve responsiveness of the New South Wales healthcare system. So it's very easy to start that. With the Crohn's and Colitis Foundation, we did email out, and clinicians handed out the questionnaire across Australia. And bang, we have 800 people. We have a superb data set, really clear vignettes, and we've collected information to guide that organisation to be able to operationalise their health issue responsiveness for their organisation. This is one of the unique things of this questionnaire, because it comes from the hearts and minds of ordinary people. It's not full of these crazy academic questions like when I was at the Royal Melbourne. I couldn't understand health efficacy questions because they were built on theory. But we wrote these questions from what come out of people's mouths in the Conover building, if anyone used to work there, people coming in for a chat. So easy to start, and all the processes are easily mapped within the manuals that we've developed, and are up for collaboration.
Well, I suspect you'll get it. Another question from Fiona Goddison, who is one of our nurse PhD fellows. Any research exploring understanding of health literacy amongst health professionals themselves, for example, to what extent GPs, and my interest more specifically is GP nurses, might understand health literacy, and how to apply this in practice as opposed to, say, only patient education?
There's been quite a few studies looking at least students, health professionals in different universities around the world. So getting a sense of their health literacy. my colleague, my team, Shandell Elmer, developed an education and assessment program for physiotherapists and implemented that and really changed their health literacy. Very early on, there was a Ballarat colleague who was getting student nurses to implement the questionnaire one-on-one, interviewing patients, and then calculating the scores, and then reflecting on, oh, this is what I know about this patient. This is what this questionnaire is telling me. But in support of practitioners and for them to strengthen their repertoire, we developed what we call the chat, pretty cool name, the conversational health literacy assessment tool. So we actually work with an enormous number of clinicians across Victoria from very diverse fields to, you know, what are the really good questions that you ask on a daily basis of your clients so you can get inside their world and to give them, you have the information to support them. So that's a tool which great for early practitioners, but also designed to really support more experienced practitioners understanding, getting deeper insights. And this has been implemented in a rehab centre in Denmark as well as some other places. So that's a tool which is designed to support clinicians. It's not an assessment, it's a clinical assessment tool, it's not a test.
Fiona, did you want to follow up with anything more there?
No, thanks for that, Richard. Great presentation. I guess, yeah, I sort of sometimes get the sense, particularly if I think about primary care, that, you know, that clinicians themselves with, you know, thinking about the system they work in and the pressure that they're under in terms of being time limited in consultations and things like that, may not feel that they have a good understanding of health literacy and how that is different to perhaps just providing a written tool or just providing patient education. And the same for practice nurses too. So yeah, it's interesting to hear about those studies.
There's a very specific education program called Teach Back. So it's a very rapid process where clinicians need to recognise that if a person doesn't understand, a patient doesn't understand, it's because it's not the patient's fault necessarily. And actually, after doing the consultation, now tell me what you're going to do when you go home. I just need to check that I've communicated well and that you understand me. So it's taking the onus on the practitioner. So it's a way of checking that the patient has understood correctly. And there's great training programs around Teach Back that will help with that too. And that could be potentially tailored to your area.
Thank you.
Well, we're right on 9:30. I think that everyone online will have found this enormously beneficial, Richard. I think there are many of us will probably like to have a separate chat with you to look about opportunities around this space. I think this is a gap that hasn't been filled yet, particularly in the antimicrobial stewardship space, as you would suspect. So on behalf of NCAS and everyone online, thank you so much. It's been a wonderful presentation.
You're welcome. Very pleased to have the opportunity. Good morning.